Yes, and we are moved to the next speaker to talking about either cells level or molecular level about how DS work. So the topic about why are weight loss and metabolic resolutions after duodenal switch the best, the mechanism behind. So the speaker is come from the obesity and bariatric surgeons work as the Gynecological Hospital from Penang. So please welcome Dr. Kiru.
Thank you very much for the very, very kind introduction. I would like to thank Dr. Kamton, Dr. Sripong for inviting me to come for the meeting in Hadiai today. I've been tasked to speak about the weight loss and metabolic resolution in BPD-DS, specifically the duodenal switch and the mechanism behind it. I have no disclosures. And of course, when we talk about surgery, bariatric surgery, we have to talk about smartphones. Okay, but I would like to say from the beginning of a phone progressed to being a portable phone where we can carry everywhere we go, and then it is in the palm of our hand where we call it as a handphone. And dramatically after the iPhone, then it became smart. You know, it's not the phone became smart, but we became smarter in using it for banking, for communication, for catching. Most important thing for me, memories of the things that we do and documenting that event and that timeless piece in life. And that's where we have bariatric surgery. The evolution from the beginning, of course, there's a lot of transitions in models, in the aim of the game and what we are doing and so on, to where we are today, where we're talking about one specific procedure, which is the duodenal switch. But the thing is, when you talk about your phone that you're using right now, if you're using an iPhone, you know what is the power, how much of memory you have, whether it's going to be a 4K and so on. So the quality is going up and up, the price is going up and up. But can we say the same with our bariatric procedures? Is the quality so high now that all of us will choose this particular procedure, or we have a lot of options which we're still not sure yet? So that's where we are trying to get to the bottom of it by understanding the mechanism. So when we talk about the switch, I think Prof. Torres as well as Dr. Sripong also has said, the idea is to restrict the stomach moderately, not to create a very too big stomach and a very too narrow end, with a long BPD limb and a common channel that is quite short. If you're talking about the gastric resection in the duodenal switch, the first classical BPD diversion that was done by Scopinaro was a stomach that was about 200 to about 500 mils. But the problem with this was the dumping syndrome, the marginal ulcers, and a lot of metabolic malnutrition, for which a BPD-DS was suggested by Hess in 1988 when he first proposed it as an open procedure. And Maso actually took up the thing and first published it. And later on, it was actually developed laparoscopically by Prof. Garnier. When we compare the vertical sleeve gastrectomy, when we excise the portion of the stomach, the greater curvature, you reduce the gastric volume, you provide the gastric restriction. We divide the duodenum after the pyloric wall to preserve the normal function of the pylorus, to make sure that gastric emptying is not too severe and avoid the dumping syndrome. So we cover two problems there. And of course, you bypass the small bowel, because the idea of disruption or decreasing the absorption of nutrients, especially glucose, sugar metabolism, and again, reducing your fat absorption by going more distally is the idea of the duodenal switch. But the problem is, in maintaining a longer common channel defeats this purpose. And if you create too short a common channel, then there's a higher risk of vitamin and protein as well as fat deficiencies. So again, as Prof. Torres said, the laparoscopic development of the duodenal switch was the defining moment, because you are creating a complicated procedure that can be done laparoscopically. But having said that, in the early 2000s, they found that when you do the sleeve gastrectomy alone, you're getting a resolution of weight reduction as well as metabolic conditions, which are just as good as the bypass, with an excess weight loss of about 40 to 50%. And it's become the most popular weight loss procedure that we see today. And if you look about the resolution of comorbidities, as presented by Prachand, they found that superior resolution in metabolic comorbidities, especially in the super obese patient with BMI more than 50, and superior weight loss as well in the super obese group. And this has been seen higher than what is seen in the Roux-en-Y gastric bypass. In 99% of patients with BPDDS, the resolution of hypertension, hypercholesterolemia, diabetes is high, as well as in 98% of diabetics who were previously on medication could be stopped and off their medication, which proves that there is a very good incretin effect with the BPDDS. Now, if you're looking at the duodenal switch as in a result of beyond 10 years, you find that the weight loss is the highest and also the longest that is maintained, with an average excess weight loss of about 74%, and in 95% of the patients having greater than 50%, maintaining more than 10 years. And from the classical duodenal switch, which is a modification of the BPD, now you have the modified duodenal switch or the sleeve plus procedures, where you have the SADI, the SADI-S, single anastomosis duodenal switch, loop duodenal switch, and of course the stomach intestinal pylorus pairing. So you see there's so many different nomenclature, change in the name. And again, recently, as Prof mentioned, in 2020, as a revision of the ASMVS statement on single anastomosis duodenal switch, we found that actually there is a consensus statement saying that this is acceptable procedure for morbid obesity as well as metabolic resolution. And of course, since Prof. Torres is here, we have to share a paper that is published as well on 10 years experience comparing SADI-S with the BPDDS and of course, Roux-en-Y gastric bypass. So in 106 patients seen at 3 years, the mean percentage weight loss was about 38%. And among 149 Roux-en-Y gastric bypass patients, the total weight loss was inferior, less, at 28.7% and statistically significant. Among the patients with type 2 diabetes, 97 Roux-en-Y gastric bypass patients lost roughly about 30%. And if you compare the 97 SADI-S patients and the 77 BPDDS patients, the weight loss was comparable, almost same, 35.5%. The improvement in diabetic status and type 2 diabetes was statistically the same between the SADI-S and BPD group, both of which performed better than the Roux-en-Y gastric bypass. So there is definitely a lot of traction in taking this procedure because of the results in terms of metabolic remission. But we have to see that the SADI-S, including, because it's a single loop, it's easier to perform, easier to dismantle as well, and it has a lower rate of internal herniation rather than the BPDDS classical procedure. So let's go to the mechanism. When we talk about restriction and malabsorption, this is probably the outdated concept of bariatric surgery, physiology. The most successful weight loss and metabolic operations these days, when we talk about it, is the limitation in the consumption of the energy, as well as limitation in the absorption of nutrients. So this is a changing concept. When we talk about the restrictive component in the sleeve, Hess introduced it because of the duodenal annular anastomosis for two reasons. One is because he wanted to create a new anastomosis in a previously non-operated area. So that's why he chose to go down into the duodenum. But of course, it's difficult to approach because when you have a previous surgery done before that, then it's going to have a lot of potential problems with vascularization. Second thing was to avoid the concept of anastomosing with the stomach to cause marginal ulcer. So the decision was taken to anastomose in the duodenum. And if you do an anastomosis in the duodenum, then definitely you have to reduce the size of the gastric volume, and that's where we came up with the concept of doing a vertical sleeve. Now, when you do a vertical sleeve, you remove 80% of the stomach using a bougie of about 40 French, creating a volume of 150. So initial cases of BPDDS, they used to measure the sleeve by injecting volume of fluid inside and measuring how much actually goes in to distend the stomach. The limitation of this gastric capacity is the first and simple mechanism of restriction, no fundus. So you can't dilate, you can't distend. When you don't have a fundus, the pump doesn't work, so you cannot break down your nutrients into smaller peptides. At the same level, the satiety peptides, satiety hormones, they influence a change in energy balance, especially your PYY, in terms of your GLP-1, GIP, and so on. Another contribution to the sleeve is there's a reduction in the intestinal absorption. So we always wonder, how does the sleeve help in intestinal action as well. So now in the present century, sleeve gastrectomy is born as a single weight loss operation procedure, and we know it's as effective as the Roux-en-Y gastric bypass, but it does have its limitation in terms of whether reflux disease and so on can cause a problem. But the main difference between sleeve and the old operations is the removal of the fundus, as I mentioned. And instead of leaving it like the Mill-Megan-Strace surgery or the vertical sleeve gastrectomy, where it's just separated from the gastric pouch. The ghrelin, we know, is produced by the fundus of the stomach, but did you know that actually ghrelin is also produced from the small intestine, testicles, your placenta, liver, and the CNS as well. So thank God we do surgery to remove the fundus and not castration to remove the testes to actually reduce the ghrelin levels. If you're talking about increasing in GLP-1 secretion, in a paper by Vives et al., it appeared to be related in acceleration of the gastric emptying. So the faster you move, your food moves down into the duodenal portion, the faster gastric emptying, the sleeve actually helps in accelerating the satiety, your fullness. So preventing your patient from eating more. The gastric resection also decreases the nutrient absorption, secondary to limiting the gastric phase of the digestion, where your stomach actually secretes pepsinogen, pepsin, hydrochloric acid, and all this is reduced, where it helps in the initial gastric digestion of proteins and other nutrients, thereby decreasing its absorption in the small bowel. So this is how your sleeve actually helps in decreasing the absorption in the intestine. Now this is a very famous picture to understand the effects of leptin and ghrelin. Okay? So leptin influences both the pro-opiomelanocortin, which is on the left side in the red, and leptin acts on the POMC center, as well as the neuropeptide Y, as well as the agouti-related peptide area in the arcuate nucleus in the hypothalamus. So leptin can either down-regulate the neuropeptide Y, or it can actually up-regulate the POMC. If you compare ghrelin, it has only one action, and that is to stimulate your neuropeptide Y as well as your agouti-related peptides. So both of these effects will be exerted on the paraventricular nucleus of the hypothalamus, which can either cause orexigenic effects to make you want to eat more, or your anorexigenic effects to eat less. So this is where the influence of bariatric surgery now, the newer concept is on gut microbiota, where we have certain gut microbiomes, like your Blautia and Eubacteriums, your cyanobacteria, Haemophilus, Lactobacillus, Akkermania. So these are all the genus that increases the relative increase in the biomes in the gastric sleeve component. Now there are also certain microbiomes that are reduced after surgery, which we have measured, and that's the Privoleta as well as your bacteroids. Now when there's an increase in the alpha diversity of the biomes with an improved firmicimycocytes as well as your bacteroids ratio, which enhances your short-chain fatty acid expression, there is a positive association in weight loss. So this is what has been found in studies that have done on microbiomes. And this is the favorable response that we get in gut microbiota in patients that undergo sleeve gastrectomy. At the same time, the microbiota gut-brain axis following a sleeve, you can see the first thing is these organisms that we have here, your Akkermansia, your Bifidobacterium that actually goes up, and your firmicutes and your bacteroids which actually go down. So this effect will actually mitigate an inflammatory process that happens in the brain as well as in the periphery. Now in the brain, what happens, the hypothalamic inflammation, it leads to a decrease in the microglial activity. So you decrease the hypothalamic inflammation that happens because of the change in the gut microbiota. And this increase or raises your enhanced leptin sensitivity. So again, leptin sensitivity increases, acts on your neuropeptide Y and helps in the benefits that we see. Now in the periphery, what happens is there's a release of inflammatory cytokines, serum lipopolysaccharides are decreased, and thereby there is a decrease in the metabolic endotoxemia that happens peripherally. And this gives a net reduction in the inflammatory response and a reduction in the mucosa-associated invariant T cell expression, which reduce your gut from being more permeable to being damaged by the inflammatory response, and thereby reducing gut leakage, reducing your pro-inflammatory condition. So the influence of bariatric surgery on gut microbiota is seen in this paper. It shows that the composition of the gut microbiota is always evolving. We're always finding newer microbiomes that actually are having benefit as well as some demerit in the surgery that is being done as well. And this improves the outcomes and influences the eating behavior. So you can actually choose to change the person's behavior by probably selectively giving them certain microbiomes to change their eating preferences, maybe less of carbohydrates, more fat, and so on. So this microbiota change affects various gut hormones and plays a critical role in the hunger and satiety, especially your ghrelin, leptin, GLP-1, PYY, and CCK. Now, this surgery-induced alterations in the gut microbiota can affect the dopamine signaling pathways, which is in the key brain regions like your ventral tegmental area and your nucleus accumbens. And thereby, bariatric surgery through this mechanism can reduce this compulsive food-seeking behavior and this what we call as craving eating. Okay. So this picture, as you can see here, the second component of the sleeve gastrectomy or the duodenal switch is the pyloric preservation, where we preserve the pylorus completely, the vascular and the neural preservation, like Prof had mentioned from superiorly. Thereby, you can see that we preserve the gastroduodenal artery, the right gastric artery. You preserve the motor function to the pylorus so that actually the antral pump keeps working. And you avoid dissecting the lesser curvature of the antrum and the duodenum. You staple across the duodenal stump without affecting the vascularization as well as the innervation. So when you preserve the pylorus, it regulates the gastric emptying. Your emptying regulates the incretin effect, and it preserves the normally functioning pylorus to be important in metabolic syndrome. So this eliminates the dumping syndrome, and post-pyloric anastomosis as well. It eliminates the undesired effects where patients will have a better improvement of life without this dumping effect and without affecting the weight loss as well. Another important thing is the alkaline mucus secretion that we have in the duodenum, where it actually prevents ulceration and stricture and complications that are frequently seen when we do a GJ anastomosis. So the interesting thing is that even in patients who are heavy smokers, because of this anastomosis being done in the duodenum, they don't have much episodes of marginal ulcers as well. The Mr. et al. Reported that in the post-pyloric anastomosis, it favored gastric emptying and it maintained the normal gastric acid secretion. When you do a pre-pyloric anastomosis, of course, there is a delay in gastric emptying and there is frequent anastomotic ulcer formation as well. So when we talk about the BPD diversion in a duodenal switch, this is the third component where you have a long biliary limb and a short common channel, usually about 200 to 250 centimeter elementary limb. And the limb is usually at the level of the proximal ileum. When you have the ileum, there are fewer hexose receptors, lesser absorption for sugar because of the mucosal surface, reduce in absorption, and you have bile and pancreatic juices in the jejunum which cannot join into the elementary limb except at the common channel, much more distally. And this warrants the maintenance of the enterohepatic bile circulation, and it limits the caloric absorption. So when you do a DS, you find that there is a limit to the caloric absorption, not more than 1,500 calories per day, which is independent of the intake that the patient can take. So it is a very powerful operation. So again, I'll refer back to the paper that was presented earlier by Prof. Scopinaro. He showed that the remission of diabetes, the mechanism together with the gastric restriction, which obeys the hypothesis of the foregut. It bypasses the duodenum and the pancreatic secretions. It goes straight into the duodenal portion, the distal portion of the ileum, and thereby triggering the hindgut hypothesis as well. It avoids the contact with the glucose, SGLT transport proteins, which are seen mostly in the jejunum. There is a selective fat malabsorption, which depletes your liver fat deposits and also your intrafat myocytes. And this actually helps in insulin resistance as well as diabetes. Now, we've also seen that there's some stimulation of the Takeda receptors, which are in the intestinal L cells, which actually help in GLP-1 secretion. So when you talk about GLP-1, we know that we have medication now available that can actually help in increasing satiety, inhibit gastric emptying, and enhancing glucose-dependent insulin release. GLP-1 is basically degraded by dipeptidyl peptidase 4, DPP4. That's another medication that we use for oral hypoglycemics as well. The direct effect on appetite regulation happens in the CNS because of GLP-1, whereby the rise in the postprandial levels is detected in patients who have undergone duodenal switch as well as other malabsorptive surgery like your gastric bypass. The other intestinal peptides which are related to weight loss and metabolic improvement after the duodenal switch include oxyntomodulin, which acts like a GLP-1 as well, inhibiting your gastric emptying and reducing your food intake, and like peptide YY as well, but it's not as potent as GLP-1. Neurotensin is another intestinal peptide that we have, and this is directly related to lipid absorption and insulin sensitivity. It increases higher after BPD surgery than your standard Roux-en-Y gastric bypass. So this is a paper from Buckwall et al. In a meta-analysis of 32 studies in 4,000 over patients who underwent BPD diversion, BPD-DS, which showed that there's a mean excess weight loss of about 70%, improvement or remission in the type 2 diabetes of about 98%, resolution of hypertension in 81%, resolution in sleep apnea of about 95%, and improvement in hyperlipidemia of about 99%. So it shows that it's a very, very good in the outcomes as well. But you need to see the long-term outcomes, and this is published by Beato et al. And they showed that in specifically for type 2 diabetes remission, maintained for a 5 years duration of about 90% of patients with type 2 diabetes who were on oral medications. As you can see here, the graph there, type 2 diabetes, hypertension as well as dyslipidemia showed significant improvement over a 5-year period. Now, the next question is all of these sleeve plus procedures the same? So if you compare a sleeve plus that is done in identical twin females, and this was published in 2023, one twin did a BPD-DS, and another one did a SADI-S procedure, and both of them were followed up for 1 year. So the total weight loss that was seen in the BPD-DS patient was about 34%, and in the SADI-S, slightly lower at 29.03%. So the BPD-DS patient presented with lower glucose, glucagon levels, insulin, C-peptides at all time points in that 1 year follow-up. Now we know, from this study, we can see that in the same genetic background, a patient who is, two patients who are identical twins, one almost similar procedure as well, one patient showed a better resolution compared to the other. Now the differences in these glucose and enteropancreatic hormone profiles observed in these two procedures that was done in these two patients suggest that there's a different mechanism in action even with a procedure that is almost similar with each other. If you're comparing, the most dreaded complication of any bariatric procedure is the mortality. In a meta-analysis of 361 studies of about 85,000 patients, the BPD-DS in terms of mortality was the highest at about 0 to 7 or to about 2.7% for all laparoscopic bariatric procedures. Now, we're talking about an era now where the complication rate is less than 0.1%. So in a series of about 1,000 consecutive BPD-DS patients, we found that a 90-day mortality rate was only 1 per 1,000, which is from pulmonary embolism, which can happen as well. So we have to have a good prophylaxis with low molecular weight heparin to prevent that one death from occurring as well. Now in that series as well, there's a major complication rate of about 7.2%, of which 1.5% was leaked from the sleeve and 1.5% was leaked from the duodenal anastomosis. So in conclusion, ladies and gentlemen, the duodenal switch includes a restriction portion, a change in the bile acids as well as the peptide secretions that we see. And of course, the main thing is there's a limitation to the absorption of nutrients that is happening. The combination of these factors makes the duodenal switch particularly effective for weight loss and in metabolic resolution for patients as well. But bear in mind also that it's also a bit more complex with higher rate of complications compared to other bariatric procedures, making it very important for us to choose the right patient who can follow up for long periods, and also be thorough in their post-operative care. With that, I would like to thank you all for your attention. Had a very good time yesterday at the hill up in this park in Hat Yai. Thank you.